vigorously. What I'm trying to say is that when I talk to large groups of folks, I want to get them started. That's the thing. And honestly, these are habits. You just make a habit. That's the key. So the bottom line is, and I'm trying to get the good news going out here. It's because if I say, oh, you have to be an athlete, you've got to be able to sustain a heart rate of 160 for 20 minutes at a time. There's got to be a lot of people who aren't going to be able to do that. And that's not the case. If you're doing anything regularly, that's a good thing. Okay? So then, this is just Phil Gorelick's work. Phil is an incredibly great guy. He started out in stroke, and he actually introduced, beginning back, oh gosh, I don't know when we started, but in the stroke meetings there is now a cognitive subgroup, and Phil was part of that. And basically, the idea here is that optimal brain health has many constructs, but cardiovascular disease and cerebrovascular disease are part of the constructs to supporting optimal brain health. And these are the recommendations to promote. It's a long list. The bottom line is almost all of this is Life Simple 7, plus getting involved in social interaction, so that is in there. But they went further than this, and I think this is the thing that you all like to do, and that is, there even is health systems and public health. That this was written to encourage health systems and public health to focus on these and make these a national priority. And I think we're doing it, but certainly in California, I suspect we're doing it across the country. And I know that Kaiser's done a very good job with motivating their staff. I think that, and who's here from Kaiser? Yeah, you get some kind of bonus points if you're,
The staff do, not the physicians. They get, there's like.
The physicians do, the staff?
No, the staff do.
The staff do, not the physicians.
Correct.
Yeah, let them
They get
die
little
off. It
bonus
doesn't
points for
matter.
doing certain activities and
Yeah.
buy things on the website.
Yeah. So, I mean, I think that's the kind of stuff we want to see happen. So, yeah, again, I'm coming back to this graphic, and the idea here is that we want to reduce the injury. That's the key. And that this injury happens, at least with cardiovascular risk and cerebrovascular risk, starts early in life. These are 50-year-olds, 60-year-olds. And again, this is Don Lloyd Jones suggesting that maybe if we pulled all of this out to 2020, we could reduce some of our vascular consequences down by 30%. And in fact, I think on average, for major cardiovascular disease, we're about 25%, right now. So I think his goal was at 30%. So, vascular factors, and the promotion of vascular health, reducing vascular factors and treating them. And using this Life Simple 7 seems to be a good way to help us with maintaining our brain health in the same way that we maintain our heart health. And my goal is to really change the way we think about this, to put the brain right up there with the heart, and the lungs, and cancer, and the kidneys, and the bones. And for us to be mindful of our treating our bodies so that we can live into an older age and continue to be valued and valuable participants in our society. Because, for you all probably know this, is that one of the reasons Social Security is going to go broke is because there are not enough young people to support. And in fact, by, I think it's 2035 or 20-something, 2025, the number of people under 15 and under 65 and older will be greater than the number of people 15 and younger. And those are the people who, and when Social Security was invented or came to be, there were 30 contributors to Social Security for every one user. It's now 3 contributors to every one user, and I think there's a tipping point coming up pretty soon. Of course, it doesn't help that our federal government's been stealing money from Social Security for a long time. So anyway, here's what you want to do. Don't smoke, watch your weight, eat a healthy diet, exercise, control your blood sugar, blood pressure, blood sugar, and blood cholesterol, and you'll have a strong and healthy brain. Now, how are we doing this at UC Davis? We're doing this through US Pointer. This is a multi-phasic approach to brain health. This is based on Mia Kiepelto's work in the finger study, where she showed a significant reduction in cognitive deterioration over time, or improvement, if you'd like to say that. The BMI was lower in the treatment group, the dietary habits were better, and the physical activity was there. Okay? It also improved actually chronic diseases. This is a side effect. Okay, so that people with 3 or more chronic diseases are the ones who benefited the most. In other words, if you have diabetes and you're exercising and you're watching your weight, you're going to benefit much greater than if you have none of these things. Does that make sense? Good. And so these are multi-domain activities, and the idea is that you pick practical, real-life situations, okay? And so Wake Forest and UC Davis are the vanguard sites. And the goal is to do a self-guided lifestyle intervention, which includes education and support, and health monitoring, and a structured lifestyle intervention where you actually have to go to these classes, getting nutritional advice, going to the classes, getting cognitive stimulation, and guideline-based health coaching, actual coaching. So where you go, my blood pressure has been this is what I need to do. What's the point of Pointer, which I like, is to test whether this finger findings, which showed improved cognition with this multi-domain, will work in a more heterogeneous cohort of older Americans, okay? And that the finger lifestyle interventions, which are different than they have different dietary habits. The finger was done in Finland, so the F stands for Finland. Okay, so they have very different lifestyle, dietary issues. Their ApoE genotype prevalence is much higher. There's all kinds of other things going on. But the idea here is really to develop a community-based infrastructure that could support a sustainable change in lifestyle for our older communities. And if we delay the onset by 5 years, boom, 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 look at that, we'll go from all of this to down here, which will save us 5.7 million. Okay? And could save us tons of money. I hate these slides, by the way, because it's really scary stuff. So with that, I'll thank you all, and I think I went a little long, but it's okay, right? Great. That was so clear, you have no question.
I have a question.
Yes, sir.
So my question is, if hypertension or stress, hypertension is linked to Alzheimer's disease and any other type of dementia, we also know that stress is linked to hypertension. And from what you presented, I did not see any information about stress. Is it because stress is hard to be quantified and more subjective? And how do we address the issue of stress? Because we also know that stress is linked to social determinants of health and all the factors that we know for sure is linked to all these chronic diseases.
Yeah. That's a really good question. The reason I didn't talk about it is because there are no trials that have looked at this. And that's where we are today. But I think stress relates to also changes in eating behavior, changes in sleep, changes in weight, all kinds of things. And so they can have all downstream effects on the cardiovascular system. You're absolutely right. The problem is that we can't seem to get a good handle on how to test the mindfulness or the meditation or these other things in a way that allows us to use it as a metric. So right now, I would say that what I do, I use exercise as a stress reducer. I do meditation in the morning. But I will tell you, I think I'd be interested to hear what you all say. I'll be like in this peaceful space in the morning. I'll get in my car and boom! So I think we do need to think about this, and I think we need to develop a metric. And there are social stressors, particularly in the United States. I'm on them, well, come on, right? There are social stressors that go on that have to do with discrimination and all these other issues that are downstream that are very, very hard sometimes to interpret and worse than that, modify. So I agree with you 100%. I think stress is a big part of what's going on. I wish I knew how to measure it and to modify it.
Thank you very much. Couple questions. The first one, selfishly, 2 glasses of wine, does that equate to 2 glasses of IPA, specifically finding the elevator?
Yeah. So there's this big debate. So this is what I say, if you're Dutch, it doesn't matter what you drink. Okay? That's the only study I'm aware of that looked at different types of alcohol, and it basically was the 1 to 2 ounces of ethanol equivalents in a day. But there's quite a bit of discussion about what's in wine and whether it's red wine or white wine. Resveratrol has been talked about as an anti-inflammatory, and that's in wine. So we're not really sure what it is. The way I say it is that it's up to you to make the social choice that works best for you. Again, that's only one part, okay? What we do want to avoid is that there is, as you probably all know as medical professionals, that there's a J-shaped curve with alcohol, and it really is truly, I've been in the Framingham Heart Study and collaborating with others, that it really is, 1 to 2 glasses or 2 ounces of alcohol a day puts you right at the sweet spot, and then it starts to come right back up, and by the time you're up to 4 to 10 ounces a day, that's like you're in trouble. And then you have all those other health problems that you get into.
I live in Napa, so it won't be a hard transition.
Yeah, no problem.
Next question on smoking. In the military, obviously we have a smoking problem. We also have chewing tobacco.
Yep.
Big problems. Is it the nicotine or is it the vehicle of smoking that's the big problem?
So as best as I can understand it, each have their own health hazards. The nicotine is what, the flammable cigarette is what we have the most evidence for, but I do believe there is some evidence about chewing as well. For those of you who know, nicotine does 2 things. It's a very good cognitive stimulant. Nicotine is actually an M1 agonist. It's great for the brain. But it also is a really good vasoconstrictor. And so, and I don't know how much nicotine, but people who chew a lot. And there are other health hazards with chewing that I can think about just, in cancer and things like that. So I don't know the answer. I don't know the answer, and I think there are people who've been studying this, and I suspect you could look at it in the CDC. The big thing is vaping's not benign either, right? We all know that now.
One last question. What's the role of aspirin with stroke prevention these days?
What's the role of
Aspirin.
Yes. Okay. It's still part of our armamentarium. Okay. The problem that we have is that there's not good evidence with these asymptomatics. So, for example, if I see somebody with one of these little holes in their brain, do I put them on aspirin immediately? And the answer is no. I assess their risk factor. That said, I'm much more likely to put them on a statin.
And you should also factor in gender, because if it's for a woman, it doesn't work as well.
Yeah.
So then more likely you'll diagnose it or give it to a male than you would a female.
Yes, that's a really good point. The other thing is that, you know, there are other biomarkers we can be thinking about or talking about when we're doing this. So, you know, when I have somebody who I see these asymptomatic, I work them up. So if I see a stroke or I see extensive white matter, I get a sleep study, make sure they don't have sleep apnea. I get a 24-hour blood pressure monitoring, because we all know how good the blood pressure measurement is in the office. And you know, it's interesting, because the Framingham Heart Study said, we measure it 3 times. It really doesn't work, okay? It's about 5 to 10 millimeters higher in the office than it is when you do a 24-hour sleep or a 24-hour monitoring. And of course, the AHA is very big on these people who, number one, don't dip, but the other group that we don't talk about is those who are only hypertensive at night. And that's probably related to sleep apnea, but it's not clear. So I actually had the opportunity to participate in some of those discussions at the American Heart Association. They asked me to come to talk about blood pressure regulation, and I thought it was kind of funny because they knew everything about it. Aspirin, what I'm saying is that I'm less likely to give aspirin than I am if I identify a risk factor, even if it's borderline. Let's say that their cholesterol or their HDL is 49 or 46 and their LDL is 97 or something like that. Those would be considered okay numbers if the total cholesterol was less than 200. But if I see these things in the brain, I'm more likely to put them on statin. I mean, and I'm looking at it, I'm treating these strokes in the brain as a stroke. So I'm doing secondary stroke prevention. And right now, we're not clear that aspirin does much for secondary stroke prevention by itself. Primary stroke prevention, it does, but secondary stroke prevention is not as clear. Statins are much more effective, I believe. Now, stroke folks can argue with me.
So I actually have, my question was going to be on statins too and primary prevention
Yes.
of vascular dementia. And there's some concern with our patients that there's a link between statins and the increased risk of dementia. If you could just comment on that. And we always try to tell them that, you know, gosh, if you have diabetes and high blood pressure, putting on a statin would be a stroke prevention, which is...
just put them on a statin.
But do you have any comments for those patients about it?
Yeah. So one of the problems with, and this is what comes out of these epidemiological studies, is that all you get is an association. You don't have any causal link. And there are probably 5 steps between the statin use in these older people and dementia. And I would suggest that it's probably what we call inverse causality. In other words, they're on a statin because they've had a disorder that sets them up for being demented, and the statin is not going to help them enough. So what I say is that there are occasionally people who get deliriums on statins, but they're very, very uncommon. So I think it's the reverse causality. It's just like, so the other reverse causality phenomenon we see is that if your diastolic is 95 and you're 83 years old, you actually have about a 20% reduction in dementia likelihood over the next 5 to 10 years. And that makes absolutely no sense, right? Okay? Makes absolutely no sense, except when you think about why their diastolic is elevated, and it's actually probably a good thing at that age. It was never a good thing back when they're 40, but at that age for them, that may be something that says that their cardiovascular system is working well enough so that they're explaining that, or they're overcoming stiff arteries, or whatever that is. So that's the problem with reverse causality.
Hi, Dr. DeCarli. This is Terrence Kelly from the California Stroke Registry. Can you speak to sleep disorders and their risk on vascular dementia?
Yeah, so what we know is that people who have obstructive sleep apnea become hypertensive and sometimes, in extreme cases, become hypoxemic while they're in their sleep. And both of those are strong risk factors for brain injury. So it's clear that sleep apnea is a risk factor for stroke. The issue is, and this has been the biggest problem, again, with reverse causation. If you look at people who have strokes, their sleep is abnormal. They have sleep disorder. It's very common. Particularly the strokes involve a certain part of the brain. So again, it's this, what's been going on. And what I say is it's really easy to ask about snoring. And it's fascinating how many times people say, yeah, we sleep in 2 different beds. I have to sleep in the other room because he snores so loudly. Doesn't mean they have sleep apnea, by the way. But and then the other one, of course, is you have them open the mouth. And if you can see the uvula, it's less likely they have sleep apnea. So those are some of the things, but you're absolutely right. They're all risk factors, and it's for the same reason that any disorder of the cardiopulmonary system can hurt the brain. And there's some questions about inflammation. Does it increase inflammation, things like that. And I say that we know athero in and of itself is inflammatory. That we know has been known for, gosh, forever and a half, 30, 40 years. So I think probably inflammation played some role, but I don't know what.
I thank you for the presentation. Excellent. Javier Lopez from Cardiology at UC Davis.
Yeah.
What about the correlation or the association, or actually causal in a way, of atrial fibrillation? And what is the contribution of atrial fibrillation to this equation? And as a second part, if you may want to comment on the alcohol relationship. So there's a connection between alcohol and atrial fibrillation, potentially.
Actually, you know what? My first publication was on alcohol and atrial fibrillation, showed that they were hypomagnesemic. 1980, oh God, 1982, 83. Wow. Anyway, so that's a very important, so atrial fibrillation is bad. It's actually probably worse for the brain than it is for the heart, I would say, for a whole bunch of reasons. But the first is that whatever's causing you to have the atrial fibrillation, okay, hypertension, diabetes, whatever you have as the underlying, is also probably affecting the brain. Okay, so even if it's atherosclerotic aortic calcification, okay, that means that there's problems going on in the entire vascular system. And again, this is a perfect example. What's happening in the heart, what's happening in the kidneys, is happening in the brain. They may not be coincidental, but it's in the vasculature. Okay, we know this, and there's actually more and more reports coming out about that. So whatever's causing the atrial fibrillation in and of itself is contributing to bad brain. Number two is, when the atrium fibrillates, it can throw clots. And when it throws clots, it can do bad stuff. And, when I was in my training so many years ago, one of my mentors, Roger Curlin, said, it's sort of like baseball. 1 stroke, you're okay. 2 strokes, you're not in great shape. But 3 strokes, you're out. And atrial fibrillation can sometimes just shower the brain. And so these recurrent embolic infarcts are very, very damaging. Very damaging. And the thing that Carlos Case and Phil Wolfe looked at this many, many years ago and simply asked the question, when you came in to the hospital with your first stroke, what did your brain look like? And often people had multiple strokes. And many of them had atrial fibrillation. Atrial fibrillation stands head and shoulders up over most of the other risk factors, but it's affecting it in parallel paths, not only in the abnormal rhythm, but also in the risk factors that lead to the atrial fibrillation. Does that make sense?
We had a presentation, just to follow up on that a little bit, related to the little devices that catch asymptomatic atrial fibrillation, and there's this question about, do we want to know, and then what do we do about it?
Yeah. I say that knowledge is never a bad thing, having more knowledge. Just have to be clear that it's atrial fibrillation and not SVT or exercise that you're getting at. I would say that it's like anything, you have to just interpret it from where it comes. And I suspect most people who come in with their stroke and have AF probably had intermittent atrial fibrillation for years before that event. And it's not uncommon for us on the stroke service to have people come in with their first stroke, and that's what caused them to be identified as having atrial fibrillation. And then, of course, HFpEF and all these others disorders are always exacerbated by atrial fibrillation. And even if you have preserved ejection fraction and you're in atrial fibrillation, your cardiac output is compromised, and there seems to be some association with cognition. So people in heart failure, just that alone, and when you're looking at 80-year-olds in heart failure, there's so many of them that have atrial fibrillation. It's contributing to their frailty, their disease, and both in their heart and in their brains.
With regard to sleep, what are your thoughts on the theories that sleep deprivation without having obstructive sleep apnea takes away healing time at night when there's maintenance for the brain?
Yeah, so I am totally advocating this. So when you're asleep.
Could you repeat it, because people couldn't hear him?
Okay, so the question is that what about people who don't have sleep apnea but aren't sleeping well? So, when I was in college, I was very proud to go, weeks with 4 hours of sleep every night, because I was taking 21 units and I'm a big guy. But in reality, that was not good. The brain does an incredible amount of reparative work while you're asleep. It clears all just the way I think about it is that while you're sleeping, it's like your pool filter working. It's like getting all that junk out of the pool, while you're not watching. It's just the little critters running around there and cleaning up your pool. And if you don't do it, you get algae and things look really pretty ugly pretty fast. That's what the human body does. And in fact, one really important piece of this is probably what's called synaptic stabilization or consolidation. And that is, memories are actually a physical event that happens in the nervous system. And you need time to do this consolidation. And the best time to do this consolidation is during REM sleep. And if you don't get enough of it, and if you don't get enough of the deeper sleep, you don't clean up the brain. And so this is a really important.
I have a follow-up on that one. So everybody who knows me, and people get to know me because I'm such an open book in this room, I am the extreme allergy girl. I'm allergic to all sorts of plant matter, molds, foods, you name it. I get 2 allergy shots a week, and I take allergy medicine 3 times a day. So the newest thing that the allergist said is, we don't want you on Benadryl anymore because it could have a dementia effect down the line. And we don't want you on this other one we put you on that helps you sleep because you can't sleep when you can't breathe from your allergies because there could be dementia effects down the line. And I'm like, yeah, but if I can't sleep, if I can't take medicine, I can't sleep. So so what are some of the agents that?
I was going to say that the best agent out there is actually antihistamines. I don't know that they alter deep sleep at all. I'm not a sleep specialist, and I can ask one of my colleagues. I don't think they do it. It's the benzodiazepines in particular, Ambien. Oh, do not take Ambien. It's a bad actor. So I would say that, obviously you want to get the best sleep you can. Exercise is a great thing to do to help with sleep disorders. But if you have to, I think Benadryl is not a bad drug. Not at all. And so I don't know.
I'll go back to it because I've been taking it for 30 years and I kind of.
Yeah, I don't think it changed. I can take a look at that. Alcohol is another. Okay, so this is why you don't drink alcohol at 10 o'clock at night. Or you stop before you get to the 6-pack. alcohol is metabolized in about 2 to 3 hours. And so